Right, okay. Okay, right. Okay, children, right now, let's start with, so what you're going to do today is, I'm going to first of all, as you all understand, now this area of urological problems, right? And then when they connect with gynecology, it's a complex problem. So these areas, their management is a sort of mix. There are urological surgeons, urologists who manage these problems. Then there are gynecologists. We also manage these problems, right? Then there are specialists dedicated only to these problems, right? So these are the ones that, generally these problems are managed together by the gynecologist and the urologist. So it's a mixture of specialties that come in, right? So there are certain very anatomical considerations as well, because the pelvis, you have, in a female pelvis, you have the bladder, which is there, okay, with the urethra. Then the uterus is packed into the pelvis, and there is a rectum. So we have overall bladder with possible bladder problems and urethra problems. We have possible uterine problems, right, which interact with the bladder and the bladder as well as the urethra, right? And there may be rectal problems. There may be muscular problems of the pelvis, which might cause prolapse, and prolapse itself will cause the bladder as well as the vagina, as well as the rectum, as well as the uterus to prolapse, right? And they affect each other. So you never get a patient purely, right, based on simple bladder cell. You might not get a patient simply on one possible aspect of the whole problem. So it's a mixture of problems that you get, right? And therefore, the urologists come into play, the gynecologists come into play, because if there's a uterovaginal prolapse, okay, for example, when the uterus comes down, it carries the vagina along with it, right? Because if you remember or know, the vagina is a tube, okay, and the womb is at the top, right? And over the vaginal, upper vaginal wall, we have the bladder, and below the lower vaginal wall, we have the rectum, right? Clear? Right. So when the uterus, which is connected to the top of the vagina, comes down due to different reasons, usually due to the incompetence of the structures that are holding it there, okay, that is how a prolapse occurs. When that happens, it carries the upper and the lower vaginal walls with it down towards the introitus, okay. So, but the bladder, which is also on top and living on a fascia, right, just above the vagina, also is pulled down with the anterior vaginal wall. The rectum also goes into the posterior vaginal form and forms a rectocele, and the upper vaginal form can form a cystocele. And therefore, invariably, the functions of these organs are affected, right? So a woman can come with urinary symptoms, say she has difficulty in voiding, and also having a large cystocele or a uterovaginal prolapse, right? So therefore, it's a mixture of urology and gynecology, or a urological problem mixed with a gynecological problem, right? So therefore, that is why both these specialties are involved in treating these problems, okay? Now, as MBBS doctors, right, or aspiring to be MBBS doctors, right, as students, what you have to understand is you need to have a general overview of this problem, right? And to understand, yes, there is a problem here. These are the general problems, and then maybe to understand or do the initial investigations and then refer this patient on, right? So this is what is expected of you all. So as at the MBBS level, yes, you need to have a general understanding of the possible symptoms that a woman can present with in this lower urinary tract symptoms, right? Or they are called LUTS. So you need to understand what these lower urinary tract symptoms are. Clear? That is number one. The second thing is you need to be able to group these together into general categories. Okay, this symptom is probably due to this. Okay, and this symptom is probably due to this, and this symptom is probably due to this, right? So generally you should be able to categorize it into certain symptoms or groups of symptoms, right? That is the second thing that you have to understand. And once you have grouped this into symptoms, right, then you need to be able to understand how this problem is investigated. What are the general investigations that are done? Number one. Second, how should the patient be examined? That is the examination. And then the investigations. Okay. And what these general investigations are. And once that is understood, then you will have a complete general overview of the problem. So that is the intention of our discussion today, right? To give you a general overview of the problems, categories of symptoms that are there, how they can be investigated, right? And to understand a general, very general overview of the investigations that are done, and to be familiar with the terminology. Because at an MBBS level, you'll be expected to talk about these investigations sometimes, right? What it means actually, but you don't need to go deep into the interpretation or the graphs or anything, right? So a general understanding is more than enough. Okay, right? So let's now talk about the lower urinary tract symptoms. One moment, sorry. Okay, so let's look at the general terminology of urinary incontinence symptoms. The first thing you need to know, right, is about stress urinary incontinence. Now, what is stress urinary incontinence? It simply is that when any physical, it's an involuntary passing of urine. The woman leaks. Okay, when and it is connected with a physical activity that increases intra-abdominal pressure. Okay, so that is called stress urinary incontinence. Okay? And what are these physical? She may cough, she may laugh, she may talk loudly, she may suddenly run, and then running will increase in her. It may be doing some sport, it may be having intercourse, right? Anything that increases intra-abdominal pressure causes her to leak, and that is stress urinary incontinence. So that is the first things that you need to recognize. Remember, children, that when a condition or the woman tells you about a problem, right, you need to be able to recognize it as a medical problem. Okay, if you listen to go to my lecture which describes how you need to, the 10-point gynecology assessment. So remember, you need to first have a definition and you need to be able to fit the problem into a definition. Okay, so that gives you the ability to recognize the problem. Okay, this is stress urinary incontinence. Do you understand? So you need to know the definition. And the definition of stress urinary incontinence is what? she leaks urine without her knowledge, number one. Second thing is, it happens and it is connected with something that increases intra-abdominal pressure. Is that clear? Right, so that is stress urinary incontinence. Next thing is urgency urinary incontinence. And what is urgency urinary? The definition is, it is a leakage of urine, right? And she is not able to hold it. And what happens is, she has a huge urge to pass urine. And then before she is able to go to the washroom, toilet, right, where it is socially acceptable, right, she leaks. And that is called urgency urinary incontinence connected with urgency. Okay, so that's the second thing that you need to know and ask the patient, right? So that's the second thing. Got it? Then there is mixed urinary incontinence, which means she has stress incontinence and she has urgency incontinence as well. You all understand? So therefore, that is the third type here. That's a difficulty to treat, because most of the time women have mixed urinary incontinence. They have urgency as well as this stress incontinence together. Okay, you do not normally get patients purely with this. Is that clear, children? Right? So that is the third thing that you need to understand. The fourth symptom that is categorized here is nocturnal enuresis. So it's an incontinence, right? Because we are talking about urinary incontinence symptoms. What's nocturnal enuresis? Okay. She gets up because she has passed urine, okay, which is not normal. Okay, so that is the third symptom that you need to understand. The fourth symptom is what? Postural urinary incontinence. And what is postural urinary incontinence? It's very difficult to understand. She passes urine when she stands up, she is seated, no problem. When she stands up, suddenly she passes urine. Okay? It's a very difficult thing to explain as to why it happens. So sometimes she lies on the bed, but when she wants to get up, she passes urine. So when the posture changes, she can have incontinence. So there is one entity that has been recognized. Although exactly why it happens, it is not known. And it is probably due to some form of change in the bladder neck or the bladder cell or the anatomical problem. Okay? Right. Then what is the other one that we need to know about? Then there is two things which you need not really worry. One is continuous urinary incontinence. All the time she is passing urine, right? And she cannot control it. And then there's sometimes which is called insensible urinary incontinence, where she passes urine once in a while, but there is no urgency. There is no urgency connected to it. There is no physical activity connected to that. So that is also one thing which you know. But for you all as undergraduate children, remember three important things. Okay, 3 or maybe 4. Okay, of the incontinence symptoms that you need to recognize. What are these again? Shall we start? The most important thing is stress urinary incontinence. You need to remember, children. Urgency urinary incontinence. You need to remember. Mixture of both things is mixed urinary incontinence, right? Then you need to know about coital incontinence. Incontinence during, did I mention that? There is coital incontinence, right? And then the other thing is insensible urinary incontinence. So, and there's something called continuous urinary incontinence. But please remember 3 things or 4 things important. Stress, urgency, mixed, and probably nocturnal enuresis. Those 4 things you need to know. I'm sure you are not going to forget coital incontinence. Okay. So 4 things you have to remember. 5th you will remember automatically. Right? Madhuranga is very happy. Okay. So those are the 4 things that you have to remember. The next thing is, it is now these are general categories, right? Then we talk about 3 large groups of symptoms. One is bladder storage symptoms. So before we do anything, right, now we are talking about symptoms. The bladder to urinate, first it stores urine. It should have the ability to store. If there's a problem with storage, then they are called bladder storage symptoms. Okay, so that large group we have to understand. The second thing is the bladder. There are sensations in the bladder. You feel that, okay, you feel that the bladder is there. So these sensations, you may have different. The woman may have different sensations. So we call them sensory symptoms or bladder sensory symptoms. That is second large group. And the third group is symptoms that occur during voiding, okay, and just after chukarano. That is post-voiding symptoms. You understand? So these are the 3 large groups that you have to see. I have talked about the general categories, right? During incontinence symptoms. Is that clear? Now, the other 3 large groups you have to understand, children, are bladder storage symptoms, sensory symptoms, right? And voiding and post-voiding symptoms. Okay? So these are the general categories. Let's go by one. What are the bladder storage symptoms? Which basically means there's a difficulty in storage, right? So when there's a difficulty in storage, what happens? During the daytime, she has to pass urine a lot. What is the normal number of times you all pass urine? Talking about females, okay? I'm a gynecologist, right? 6 to 7 times is a normal thing, right? If you are passing urine 10 times, 12 times, 15 times, that is not normal. Okay? So that is what is called. That is called increased frequency. So frequency is a storage symptom. Again, the bladder cannot store for a long time. Stores only a small amount, and she has to pass urine. Is that clear? Then the other storage symptom is during the night, where she has to pass urine. She has to get up and pass urine, which is called nocturia. 1 or more times. Normally, once a woman is asleep, okay, then she can sleep until, say, morning, whatever it is, right? And then she can go and pass urine, okay? But if she has to get up in the night, right, then 1 or more times, then that is not. What is that called? That is called nocturia, okay? So if the woman is getting maybe once, maybe it's physiological, but if the woman is getting 2, 3, 4, 5, 6 times in the night, right, that is not normal. How is it in the? So she has to get up to pass urine, right? And then she sleeps again, and again she has to get up to pass urine. So that is nocturia. Okay. Remember, enuresis is an incontinence symptom. She wets the bed and then gets up. Okay. But nocturia is she feels. So she gets up. She wants to pass urine and she goes because she has the. She feels that the bladder is full. Okay. So that is the second one. What is the third symptom, storage symptom? Is urgency. So remember, urgency and frequency can be together. And what is urgency? She feels the urge to pass urine and she has to go. She can't wait. And that is urgency. Okay. The other one, frequency, is that she feels that the bladder is getting filled, but she doesn't need to run to the washroom, right? That is frequency, but she feels uncomfortable, so it goes. Urgency is when she gets the feeling, she can't just hold on to it. She has to go. Do you understand the difference between frequency and urgency, right? However, the woman can have urgency as well as frequency at the same time, right? And then we have overactive bladder syndrome. What does that mean? That is urgency, right, coupled with frequency, right? If you have now frequencies without urgency, okay, you have to go many times, right? Then you have nocturia, you have to go many times. Urgencies, you have to urge to go, you can't hold. And overactive bladder symptom is, as I told you, these things coupled with each other. She has the urge to go, right? And she has to go very frequently. So if she is going with urgency very frequently, that is overactive bladder symptom. What does that mean? When the bladder is filled slightly, the bladder starts to do this. And she can't hold on, so she has run. You all understand, children, the difference between them? Are you all confused? Yes, Ratnayaka, are you confused or are you all right?
All right, sir.
Excellent. Any questions there? No? Right. So these are the bladder storage symptoms. So let's summarize again. What are these bladder symptoms? A woman may have frequency during daytime. Okay? There is no urgency involved. Right? She goes many times. Then she can have frequency, increase in frequency during the night. That is nocturia. It's given a special name. Third thing is she can have urgency. So once in a while, when she gets it, she can't hold it. So that is urgency. Right? However, if she gets it many times, right, or all the time, coupled with urgency, that is called overactive bladder syndrome. Okay? So these are the few things that you need to know about bladder storage symptoms. So if you hear these symptoms, you think, oh, the bladder can't hold much urine. It's causing a problem. Okay. Next is sensory symptoms. Sensory symptoms are very easy to run. But increased bladder sensation. She passes urine or want to pass urine, you feel it. She feels it's very filled. Okay. That is an increased sensation. Then she has reduced. It fills up, large volume in the bladder, she doesn't feel it much. Only when it is very large, which means the detrusor stretches and it has lost its ability to contract much. Right? So large volumes in the bladder. There's this problem with the sensation. Okay. The third thing is she can have what? Absent bladder sensation. That is usually happens when there's a neurological problem. Right? When there is a neurological problem or some form of a trauma, right? She does not have bladder sensation. What happens then? There's a large bladder, it overstretches and she might start dribbling because of the large bladder. Okay? So sensory symptoms, it is very easy. You have increased, reduced and absent. Okay? Sensation of the bladder. Is that clear, children? Right? And the third thing is, what does that mean? Voiding problems and problems that comes after voiding. And what are these? Right? What are the voiding problems? Hesitancy. It's difficult to start. Doesn't start. Right? So that is called hesitancy. Right? So that is, what is this? This is a voiding problem. Hesitancy may be due to neurological, physiological problems, right? There is no coordination. It may be due to the urethra being where the pressures are very high. It may be that the bladder contractions are not coordinated, right? So that is one problem. Then the second thing is what? Intermittency. Chutta chuyana? No. Chutta chuyana? No. Chutta chuyana? Aduena. So bit by bit. You understand? Right? Okay. So that is intermittency. So you can have that because it is uncoordinated bladder contractions. Okay. So that is intermittency or intermittent. Next thing is slow stream. So remember, most women will enjoy good stream. Yeah. Right? Like a gun and they do it. Right? But if it's slow stream, that's not good. Okay. So they will say, I had a good stream earlier, now I have a, right? Understand? Or you can measure it by the curve, that is normally men. Those days I had a nice curve, now it's a small curve, right? So that is also a stream, okay? So slow stream is something that you have to understand. These are all voiding problems, right? What is the other thing? You can have strain into void. You have to, somehow, so you put in a lot of effort to void. So you strain to void. So there is also a problem of what? Void. Then some women will, there's something called strain. There's no stream. It's like, right? That may be due to an anatomical problem. So you have strain. There's no stream, proper stream. Okay? And you can sometimes you can have strain. Next thing is what? There's a sensation of incomplete voiding. That is what? Once you do the chew or urination, still you want to do it. Right? And then sometimes women need to first you void, and then you have to void again. So it is called what? You have to re-void to feel okay. So that is also a problem with voiding. Is that clear? Next thing is, once you do the chew or micturition, after that there's dribbling. Put the leak, small amounts leak. Right? That is called post-micturition dribbling. Right? And of course, what are the other symptoms? If there is pain during or if there is dysuria, right? Those are also connected to voiding and post-voiding symptoms. Is that clear? So this is an overall view, children, of the 4 categories that you have to understand the symptoms that the woman is telling you. Right? This is very important for you all when you all take the history. Right? You all understand? So now you have to have a very good overview as to what to ask. That is all. There won't be any very high-fi symptoms. These are only things that you need to know, and when you elicit the history, so that you are going to sound very smart when you say, I am talking about post-voidal symptoms, right? Or I'm talking about bladder storage symptoms, okay? And I'm talking about sensory symptoms, right? So that when we are listening to you, we know, oh, this man or woman knows what she's talking about, okay? Right? So let's go again, right? What are the urinary incontinence symptoms you need to know? Children, I said 4 things, right? But I put in an extra one, which you all are going to remember very well, okay? What are these? Talk with me. Stress urinary incontinence, urgency urinary incontinence, mixed incontinence. What is the other one? Nocturia or nocturnal enuresis, right? And bonus, coital incontinence, right? And the other things you don't really need to worry too much. That is continuous and insensible urinary incontinence, right? That is gold medal. If you want to do the gold medal, you do the 2. But otherwise, you will get a small gold medal for the coital incontinence and large one if you do it in the other 2. Okay? So that is the urinary incontinence symptoms. Then the bladder storage symptoms, right? What are these, children? Daytime, there is a frequency. Nighttime, you have a nocturia as a frequency, increased frequency. Then urgency, right? Is she can't hold it. When she gets it, she can't hold it. And then you have what? You have overactive bladder symptom, which is the coupling of urgency with frequency. Is that clear? Right? That is storage. Then you have sensory symptom. That's easy. Increased, decreased, absent bladder symptom. Okay. Then the next group of symptoms is voiding and post-micturition. And what are these, children? Voiding and post-micturition. What? One is hesitancy, slow stream, okay, intermittency, choose, right? Then spray, right? Then strain into void, Okay. Then you pass urine but incomplete empty, right? Then you need to revoid, chew kara, I chew kara no. You understand, right? Then once you do the chew or maturation, there's dribbling, dribble, right? And of course, the infection things. What are these? Dysuria, right? That is also, pain during that. And of course, we have to talk about what? Urinary retention. I forgot to talk about that. Again, she can't void. There's retention. Okay, that also goes into the voiding problem. Void can retention and on. Right? So that is one. Do you all understand? So those is the symptoms that you need to understand. Is that clear? Right. Give me 1 minute. I need to take a call. I have a patient. Okay, sorry. Now, so this is what you ask the patient. Okay. The next comes the examinations. You need to examine the patient. So the examination does not differ from any other gynecological or urological examination, right? What are the simple things that in a just urological problem? Of course, abdominal examination. Abdominal examination will show you if there's a bladder urine retention, you will see a very large bladder. Remember, any abdominal mass you see, right, and you suddenly get excited, oh, this is a big mass and that, right? Make sure it is not the bladder. Ask the patient whether she has passed urine or not, right? And also, if you are not sure as a house officer whether it's a bladder, you can always, if the scan is not available, and if it's a very rounded, very doesn't look like a very hard mass on something soft but quite firm, right? And say like a ball, okay. If you think it might be retention, then of course you can ask. If she doesn't pass urine, you can always catheterize, right? And if there's a lot of urine, suddenly your cyst or mass which you have been enjoying so much and telling you have discovered goes off, which is the bladder. Okay. So of course, abdominal examination. And you might find other things that is causing the urine symptom. Retentions might be caused by fibroids. Okay. Retention may be caused by masses in the pelvis. Retention may be caused by cancers, malignancies, right? So those things can be there. So abdominal examination will give you. Then the vaginal examination, of course, you need to do the vaginal examination probably, and you have the inspection, and you need to see whether there are signs of, for example, urinary leakage. You will see the excoriations and the changes in the skin, which would mean that she's been either having stress incontinence. There are changes in the skin due to the constant exposure to urine. Okay, and there may be infections, inflammations there, which you might see. Right? At the same time, the labia may be large, hypertrophic. That causes sprain. Okay, because to have a nice urine stream, that area needs to be exposed, right? So whether the urine will come out. However, if there is a hypertrophic valval folds or labia, what happens is the urine hits here and there and sprays. Okay, so that may be one reason that she may be having problems, right? So the inspection of the urethra. Then, if you want to look at the urethra, because there can be urethroceles, right? There can be cystoceles. There may be uterovaginal prolapses, right? There may be incontinence. All these, you can do a sim speculum. You lay her on a side, put a sim speculum, pull down the posterior vaginal wall, and then you have a direct view of the anterior vaginal wall. What does the anterior vaginal wall have? The urethra and the bladder that is sitting on top of it. And of course, you can see the uterovaginal prolapse. MBBS level, you might not require to do that. So if you just recognize whether there's a prolapse, children, that is more than enough. Okay? And the prolapse, if you grade it scientifically, we have to do what is called the pelvic organ prolapse score, right? It is a scientific way of grading a prolapse. For your children, if you are looking at a prolapse, what are things that you have to do? You just need to tell us whether it's a first degree, second degree, or a third degree uterovaginal prolapse. Okay, and how do we say that? First degree is that the lowermost part of the cervix, right, has come up the introitus, but has not coming out. That's the first thing. Okay, so it has come down the vagina up to the introitus. So it is not in its usual position, things I can't, but it is not coming. Second degree is what, children? Right? Is that it's coming out of the introitus, the cervix is coming out of the introitus. But when you put your finger behind and over it, children, you cannot, your fingers do not touch, you cannot touch, because still there is the cervix and the womb left in it, between the anterior and the posterior walls. Do you all understand? When the prolapse comes out like this, right? When you put your fingers here and here, if you still feel the body of the cervix or the, that means it's a second degree prolapse. Okay. However, if everything has come out and the uterus is small, and if you put your fingers on the anterior and the posterior walls, and if you can feel your fingers through the layers, and you can't feel a body of the uterus, then it's a third degree uterovaginal prolapse. Right? You all understand? That is all you have to know, children, about the degree of the prolapse. Okay? And then, of course, you need to know if there is no prolapse or maybe a first degree, but it's mainly, when she strains, mainly the anterior vaginal wall is jutting out, it's a cystocele. Okay? Which might cause the problems that I spoke about. And of course, if the posterior vaginal wall is come out, it's a rectocele. But these things we will talk later in uterovaginal prolapse. This is not related to. It can exacerbate and make problems bigger in urinary problems. But in the examination, you need to be able to identify a cystocele. You need to be able to identify a rectocele. You need to be able to identify a uterovaginal prolapse. And you need to be able to say whether it's a first degree, second degree, or a third degree. Do you understand? Scientifically, if you want to go for double gold medals or triple gold medals at the same time, then you can talk about the POP score, pelvic organ prolapse score, which has certain points, and you say, okay, in relation to this point, and this is here, and then it has a scientific explanation as to how much the prolapse is bad. Got it? Okay. Right. So that is all you need to do about the inspection. And of course, when you are doing a vaginal examination, right, for these patients, we need to check for anterior vaginal wall scarring, whether there's a lot of scars there. Because that can tell us, okay, a lot of surgeries has been done, and whether we can do a certain surgery later on. So those are the things that we need to find out, right? So those are the examination part of this patient. And the vaginal examination will also tell us whether the womb is big, whether there's a fibroid, whether it's impacted, right? So those things also the information will tell us. We can get those information during a vaginal examination. Clear? Right. So that is the physical examination part. Okay. So it is a conventional abdominal examination, conventional inspection of the vulva, urethra, right? As I told you, remember the changes from the urine leakage, right? Abnormality of the vaginal lips, right? And then, of course, the examination part, you should be able to say about the prolapse, a cystocele, rectocele, and if the prolapse is first, second, or third degree, right? Ideally, children, the prolapse or the degree of the prolapse should be examined with the woman standing, right? And where she is asked to standing with the legs abducted slightly, and she is asked to do a Valsalva mano or push, right? And then the prolapse will come out properly. Because when she is in the lying down position, it sometimes doesn't come out very well because the gravity is not there. Okay, right? So therefore, ideally that is that. But as undergraduates, we don't do that, right? A postgraduate will be expected to do that. So remember, that is how properly a woman with a urinary or a pelvic prolapse with or without urinary problem is examined. Is that clear? Right. Any questions so far? Right. So if you want, you can type into the chat. Okay. So that is our. Now let's look at the investigations that are done, right, for these patients. First of all, remember, we have several investigations that needs to be spoken about in everything. How in a woman with any of these symptoms are investigated. There are three things you have to tell us, children. Okay, and I will tell you that. The first thing you have to tell us about the midstream urine specimen for culture and antibiotic sensitivity test. You have to tell us that. Because if the woman is having an infection, you need to treat it. And that can make the symptoms go away. Okay? So there is nothing called a UFR. It has to be a urine full report or a midstream collection of urine with a culture and an antibiotic sensitivity ABST. Okay, if nothing is grown, the ABST will not be done, but it will tell us whether there's an infection. Is that clear? So that is a must for all women presenting with the problems which I discussed earlier. Is that clear? The second thing is, it's a selective thing which we have to do. And what is that? That is called a frequency volume chart. And in other words, what is that? It's a chart, right, which tells us the frequency of whatever problem she has and the volume that she drinks and urinates. Okay, a standard frequency volume chart or a bladder chart, right, or a is something. It's a tool that you have to understand. It's a simple tool that will give us a lot of information. Okay, now what does that mean? So let's look at it this way. When the woman gets up from in the morning, she writes on the top of the chart. It's normally kept for 3 days. Not 1 week, 2 weeks is difficult, right? So normally 3 days. When she gets up, she puts the time. Okay, time I got up. Then when she goes to bed, at the end of the chart, she puts the time she went to sleep. Okay, so that is so. And in between there are columns. The first column is the time. If something happens, that the time. Okay, in the first column. The second column is any amount she drinks. So she has to measure everything. Okay, so she has to have a jug. If she's drinking tea, okay, measure okay, 300 milliliter. 930 300. Orange juice, raw katta, so whiskey with raw, right? You 200 ml, whatever, wine, whatever it is, you put in. Got it? Then the out part is the different one. The out part problem is what? You have to pee into a jug to measure. So she has to pee into a jug, and when she pees, 200 ml, 200 ml out. So anytime is in, you write, and anytime it's out, you write the number. Okay. Then the third column is if she becomes incontinent at whatever time. Right? So say she puts a time and she leaks. She puts a hurry. Okay, tick or a cross. I leaked. If there's anything connected to that, she can write it in the box. Okay. Okay. Coughed and tick, leak. Leaked, or this is a cough. Or you have urgency and you ran to the toilet and then she leaked. Running to the toilet, she leaked. Do you understand? So that is the column that is going to tell us how she leaked, whether it was with just when something happened and she leaked, or whether she had an urgency, right? She ran to the cylinder and she had urgency incontinence. Do you understand? That column will tell us that. And the fourth thing is column is, which is called the urgency or urge score, right? And the urge score is from 0 to 4 in the chart. Okay. So whenever she leaked, right, or when she passed urine, she puts a urge score. And 0 means what? No problem. She just went to the toilet. There was no problem, right? She just passed urine, right? So you put 0 when she passed urine, because out is there, out, okay, 200 ml chukra, the urge score 0, which means a normal urination, right? 1, 2, 3 means what? She feels the urge, but she can hold on. 2 is she feels the urge, but she can't hold on for long. 3 is she feels the urge, has to go run immediately. Very difficult, severe. And 4 is before she feels the urge, before she ran, she leaked. That is incontinence. Okay, so she need to write that. Is that clear? Okay, so this is the frequency volume chart. You have to explain to the patient this is how it's done. And it has 4 columns. Time, first when she started to sleep, when she didn't sleep, or when she gets to bed. Then time, in, out, incontinence episodes, and what is connected with. And the 4th is urge score. That will tell us the severity of her urgency and urge incontinence. Is that clear? When you look at the whole chart for 3 days, you get a very good idea of what is happening. What are the fluids that she can take? Oh, maybe we can adjust that a bit. Okay. Then how many times she she passes urine? Okay, this woman has frequency. Right? In the night, she has noticed especially, right? She has to get up. Oh, okay, this woman has nocturnal or nocturnal enuresis. Then she writes down, okay, leaked. Every time cough, sneeze, coitus, whatever it is. Ah, this woman is having stress incontinence, probably. Okay. Next, all the time she's putting 4. Oh, this woman is having urgency incontinence so many times. It gives us, okay, I don't think this woman can even live a normal life. All the time she has the urgency and she runs. Okay. Then she, in the out chart, she has 50 ml, 60 ml, 30 ml, 40 ml. What is happening? The bladder can't hold more than 40, 50 ml. There's a problem with bladder storage. Okay. Then she, or if we find that the voids are 300, 400 ml, 500 ml, okay, that sounds good because the bladder capacity seems to be good. So you get an idea as to how much the bladder is fitting. Now, what is the normal bladder capacity? Between 400 and 600. Normally, a woman will start to or can hold on for about 400 cc. So she can have the, she can hold on to that before voiding. Okay. But if a woman is voiding every 100 ml, 100 ml, then there's a problem. Got it? So this frequency volume chart, right, will give us some idea as to what is happening with the woman. And it has to be done for 3 days. Is that clear, children? Right. So that is something that you need to know. And that is something that you can give the patient and explain to the patient. And then she comes back with it for the next session. Then the third thing that you need to talk about is the pad test. Okay. Which is the basic investigation for urine problems. What is the pad test? There is a 1 hour pad test and there are other rather difficult pad tests. But for the pad test, children, you have to have a proper scale. So you weigh the pad and you give the pad to the woman. Right? And then the first 15 minutes, she doesn't do anything. The next 30 minutes, she does a normal walking around, climbing stairs and this and that. And the last 15 minutes, she does rigorous exercise, jumping up and down, doing exercises, okay, like different things, trying to strain, cough hard, this and that. So that's it. And then at the end of 1 hour, you weigh the pad. And if there's an increase in more than 2 grams, okay, that is considered a positive pad, which means she's having incontinence of some sort. Is that clear? Right? So if it is more than, if the change is more than 10 to 15 grams, then that is severe incontinence, severe problem. Okay. So there is a third test that you need to know about basic investigation. So to summarize again, children, the three basic investigations that you would want to do are what? First one is UFR or midstream urine, culture, and ABS for any woman coming with urine problems. Clear? The second basic test which she has to go home and do it is what is called frequency volume chart or a bladder chart. Okay? And the third thing is a pad test, which is not done often, may be done in university, is a pad test, which is a basic investigation. Got it? Okay? And then we move on to specialist investigations, which I want you all to have an overall view as to what they are. Okay? Right? So that you know at least the names and you understand the basics behind it. And therefore, you are going to sound like a very professional medical students, a very knowledgeable medical students. And when you say these words, we might even not even ask you what these are, because we'll be so impressed with you all. We will give you handout gold medals and distinctions, okay? Right? So what are these specialist investigations that you want to do for this week? The first is, children, uroflowmetry. As it sounds, what does it do? You measure the flow of urine, right? And normally in a uroflowmetry, you get a curve, right? There is a commode, you sit on it and you do the okay? And it measures the flow. And it gives us a nice chart, electronically chart, okay? And what does it say? In the first seconds, this is the flow, right? This second is the flow, that is the norm. So normally, a woman should be putting out about 15 ml per second. So, and it's normally a bell-shaped curve. To start off slow, then zoom, and then so it's a bell-shaped curve, okay? So that is the normal urine. So what will that give us? It can give us various problems. It can give us the amount, right? That will tell us about the volume of the bladder. It can also tell us about the stream, about intermittency, intermittency, right? Then about the volume, intermittency, hesitancy, right? All this you can talk about. So it gives a general idea about the storage, right? It might give it, because once everything has gone out, you will find about the storage, right? Right? Then voiding, what happens in voiding, it can gives us a general idea. You understand? So that is called uroflowmetry. Got it? The second thing, which you will sound very, very good if you talk about it, is called subtracted cystometry. You all understand what that means? What is subtraction? You subtract one value from the other. Cysto is what? Bladder. Metry is you measure the bladder. Basically, we are looking at few things. What is this? We are checking the pressure in the bladder, inside the bladder, and that is called bladder pressure. And how is it measured, children? It is measured by putting in a specialized sensor into the bladder with a catheter. So that sensor measures the bladder pressure, and that is put on a graph. Okay. Then we have to check the abdominal pressure. Now you can't put a sensor into the abdomen. So you have to put the sensor into the rectum, and that gives us closely the abdominal pressure. So then you get an abdominal pressure. And then we measure something called the pressure that is built in the muscle or the detrusor, and we call it the detrusor pressure. Because we cannot measure the muscle directly without putting a implant into it. And therefore, what we do is we measure the abdominal pressure and we measure the intravesical pressure. So we have an abdominal pressure and an intravesical pressure. When we subtract the intravesical pressure from the abdominal pressure, we get an approximate value of what is happening with the detrusor, and it is called the detrusor pressure. You all understand? So we are measuring three things: two things directly, abdominal and vesical pressure. And when we subtract one from each other, we get a dead-crucial pressure, which is an indirect measurement, and we get the graph for it. And how do we interpret these children? We interpret it like this. If the woman has stress incontinence, okay, the bladder is just waiting like that. Okay, it doesn't do anything. However, when there's something that increases intra-abdominal pressure, laugh, cough, coitus, right, shouting, running, sport, anything, the intra-abdominal pressure increases, right, and that works on the bladder and she passes urine. Okay, so the muscle of the bladder doesn't do anything. It's the intra-abdominal pressure that is pressing on the bladder, right? We will speak about this at length later. So in our graph, what do we get, children? The intra-abdominal pressure, or from the sensor in the rectum, the intra-abdominal pressure will rise. Okay, the intravesical pressure will also rise because the intra-abdominal pressure will cause pressure on the bladder. So intravesical pressure will also rise. However, they will be equal. And when you subtract one from the other, the dead-crucial pressure will be zero. You all understand? So in the dead-crucial pressure graph, we get flat. Intravesical and intra-abdominal pressure, we have high graphs. You subtract, you get zero. So no dead-crucial pressure, increase intra-abdominal pressure, and increase intravesical pressure. And what are we looking at, children? We are looking at stress urinary incontinence. Is that clear? And these studies are called urodynamic studies, right? So is uroflowmetry and substatic cystometry, and there are other things. Those are all urodynamic studies, how the urine moves. Okay, urodynamics. Okay, right. So that is one. Now, if the intra-abdominal pressure does not increase, but if the intravesical pressure increases, right? If you subtract the increased intravesical pressure from the absent intra-abdominal pressure, and that is a dead-crucial pressure, and the dead-crucial pressure has also increased. Okay, so in the graph, intra-abdominal pressure is flat, dead-crucial pressure is high, and intravesical pressure is also high. And what is that? This pressure has been, intravesical pressure has been created by the dead-crucial contract. And what is that, children? When the dead-crucial is contracting, it's an dead-crucial overactivity or dead-crucial origin is zero. So this is urgency incontinence. Is that clear, children? Right? And of course, if you get both, samarata pattern again, samarata may pattern again, and you get what? That is a mixed incontinence. Right? So this is what, in a nutshell, what urodynamic studies or subtractive cystometry means. Right? So normally this can be done if you are going to do a surgery. It's better to do this, right? But we don't have facilities in Sri Lanka. However, in most countries, but they are going away from it. But still, there's a legal implications in. If you do a surgery which may not be reversible, okay, and then you get a bad outcome, and you suddenly find that you have treated her surgically for something that is not properly, you know, you are not treated what exactly we were treating for, and her symptoms worsens. Then, of course, you have no legal standing to say, okay, I treated for stress urinary incontinence, I did the super operation. But then she had urgency and urgency incontinence. Now I have done a super operation to do to the bladder neck to stop the stress incontinence. Now she can't live because the urgency and urgency increased so much, right? Because for stress incontinence, which we'll discuss later, you tighten up the bladder, children, okay, to prevent the leakage. But if she has urgency and urgent incontinence, against the tightened bladder neck surgically, this is going to contract some more, and it's very difficult for her, and the symptoms will increase. Then she will sue you. Okay, but in the urodynamic studies, it was told, okay, this woman has stress incontinence. no urgency, urge incontinence. Then you have a legal standing. Okay, I did the test. It proved it's stress incontinence. And therefore, for stress incontinence, the mainstay of therapy is surgery. So therefore, I did it. Okay, so you can defend the management. You all understand? So remember, if you are going for a surgical intervention, it is better maybe to do urodynamic studies. However, if it is not a surgical it is not essential for us to do urodynamic studies, which is a very messy, difficult test. Okay, it's a difficulty because you have to put something in the rectum, something in the bladder. So, and you have to fill the bladder with saline, right, to increase the bladder sensation, right? While you are feeling, then you get the feeling, then you are asked to. So I forgot. So first you fill the bladder, right, in this subtractor cystometry. And then when it's up to a certain level, then with the pressure catheters inside, then you ask the woman to do certain things. Jump about, do exercises, strain, all that to see whether she leaks. When she leaks, you look at the graphs, okay? Or if she leaks and she has urgency when the blood is getting filled, then you the graphs will show what is happening. You all understand? But it is not a natural way to do it because that is not the natural environment. You do something by filling the bladder. You all understand? So it might not reflect the actually what she has. So therefore, it's very difficult to go alone on urodynamic studies as well. Therefore, it is not absolutely essential to do urodynamics if you are going to treat her with medication as a trial. Okay, so you can treat her with a trial, and if it is not, and if you are contemplating surgery later, then of course it's better to do urodynamics, confirm your diagnosis, and then do. However, urodynamics may not be 100% confirmatory. So you need to explain to the patient that although the urodynamics say this, there's a possibility that you might be having something else. Okay, that it might not be stress syndrome, it might be urgency, but it might not be reflected very well in these artificial studies which we are going to perform. Okay, is that clear, children? So if you know the two definitions of uroflowmetry, which is just passing urine into a meter and then judging the stream and how fast it goes and the stream and everything. And then the second thing is subtractor cystometry, which is a more complex study, right? Those are the two things which you need to understand. Of course, there are other things, right, with very big names. One is video urodynamics. So you give a contrast, and then in front of a screen, you do X-rays, or you look at the patient passing urine through a fluoroscopic screen, and then you do a video of the whole thing and you study it. It shows that a contract and a urine, how it urine go, how it feels, everything. For example, then you can measure the pressures in the urethra itself. So that is called what? Urethral pressure studies. Okay, that you can. So because then you can watch the bladder pressures and the urethral pressures and then come to conclusions, all that. Then you can do neurological studies. Those are called neurophysiological studies. You can measure the nerve conduction in the urethra and the bladder. Okay, so then you can do ambulatory urodynamics, where the catheters are fixed and then she is allowed to go about her day-to-day activities in 3-4 hours, and then you look at the measurements. So there's an ambulatory, she goes about her door. So it's not in a lab setting as such, right? Do you understand? So those are the things that you do. And then those are the types of specialist studies you do. So if you go, remember children, for you all, uroflowmetry and subtractor cystometry are the two main things. Then ambulatory cystometry is video urodynamics can be done. Urethral pressure monitoring can be done, right? Neurophysiological studies can be done. Then you can do ultrasound to find out whether there are any problems in the bladder, right, on the anatomical structures. Then you can do X-rays to see whether there is a problem where you can, and especially X-rays with contrast, right? You can do cystograms, specialized X-rays with contrast. Then to check out for fistulas, you can do CT or MR IVUs, intravenous urograms. You give contrast and it goes into the kidney and it comes to the ureter, goes into the bladder. And if there are fistulas, it drops into the vagina or the peritoneum, or from the ureters, it goes on to the vagina. So you can detect different types of fistula. They can be vesico-vaginal, okay? They can be vesico-peritoneal. They can be uretero-peritoneal, or they can be uretero-vaginal. You understand? And that can only be detected by CT IVUs. Okay. So these are the specialized investigation which you can. And finally, to investigate that, we can do a cystoscopy. You put in a telescope into the bladder and you can take biopsies if you want. And these are normally done by urologists as investigations. You all understand? So these are the things that I wanted you to understand as far as what the investigations are concerned. Okay. And of course, if you are looking, there's another one, another specialized test. If you are thinking of thinking of a fistula, you can do what is called a leak test or a 3 swabs test. You put 1 swab into the vagina, the 2nd swab in the mid vagina, and the 3rd swab outside. You fill the bladder with methylene blue, saline with methylene blue, and you ask her to go about a normal things or cough, sneeze, or anything. If the outer swab is soaked with blue, that probably she may be leaking. Okay. If the middle swab is leaked, she may be have a ureterovaginal fistula from the urethra to the vagina. And if the upper swab has blue in it, that probably she may be having a vesico-vaginal fistula. So that's a rough way of saying, but that is one test that can be performed if you do not have facilities for CT IVUs and CT MRIs, right? MRI IVUs, right? So you do basically you do a contrast intravenous urogram, and you do it with images are with MRI or images are with CT. Okay. So this is all which I wanted to tell you today, right? And that gives us a general overview of what you have to know before we go on to the other things, children. Specific problems as to how to treat them. Okay? You all understand? So we will go one by one. I will take you through the main ones only, which is what? Stress incontinence, urge incontinence, urgency, right? Nocturnal enuresis maybe, right? And those are the main ones. And what we do to treat them: medical, surgical, and other physiotherapy methods, which is used for all this, right? So that are the next lesson and the next lesson, which we will do. Clear? So that is all which I wanted to teach you all today. Any questions on this? So in summary, children, I want you to understand these are lower urinary tract symptoms, or what we call LUTS. Okay. For this, first of all, we have to understand the definitions, which are 4 large groups. You have urinary incontinence symptoms. You have bladder storage problems. You have sensory problems, bladder sensory problems. And a woman may come up with what? Voiding and post-voiding problems. Okay? That you have to know those. Then you have to know what to do with the examination. Abdominal, vulval, speculum, right? Usually with standing up, you have to do an examination for prolapse symptoms. Then, of course, the vaginal exam, what you need to do, right? And so those are the examination part. Then, of course, the investigations, you need to know the basic investigation, children. What are these? Urine full report or midstream urine with culture and ABST, the frequency volume chart, children, and the pad test. These are the 3 basic investigations that is done, right? And then the specialized investigations are all the other things which I told you about. Uroflowmetry, you need to know the basic understanding. Then subtractor cystometry, you need to know. But highly specialized ones are what, children? Video urodynamics, right? Urethral pressure profilometry, then neurophysiological studies, right? Then there are other things like we cystoscopy, you go inside and have a look, right? And there are imaging, ultrasound scan, X-rays, CT views, all these are specialized investigations that are done, right? So that covers entirely what you need to talk about if you are asked about investigations, examination, and the symptom profile of the patient. Okay, so this is the base, children, and on that we will build in the next couple of sessions about the other problems connected to the urological problems that you need to know about. Okay, right? Any questions that you want to ask me? Which means you have fully, completely, and thoroughly understood it. I'm very happy that I have so very, very, very bright students. No questions? Okay then, time to sleep. Okay. Good night.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Good night.
Thank you, sir.